Welcome, everyone. Thank you so much for jumping through all the hoops that were required today, extra hoops to join our Zoom. This is our Caring for Caregivers learning community, and we're going to give a brief overview of C4C and the purposes of the learning communities. And then we're going to kick it over to the National Alliance for Caregiving to get us started with a discussion of the new CTS codes and implementation. First, I'd like to go back, thank our funders. This work was started at Rush several years ago with the initial support of the RRF Foundation for Aging. We now have support from the John A. Hartford Foundation to scale and spread this program nationwide. We also partner with others, including the Institute for Healthcare Improvement and many age-friendly health systems, of which Rush is one, and many of you are also. And these groups provide invaluable advice and input as we work to spread this work nationwide. I thank you all for being here today. The purpose of the learning communities, as you can see there, is to create a collaborative space for all of us to regularly gather to all teach, all learn about caring for caregivers, as well as guide model, implementation, workflows, and sustainability. And of course, today we are focusing on the utilization of the new CMS Caregiver Training Services codes. The structure of these learning communities is to allow time for learning, questions, and discussion. Again, today we're going to focus on the CTS codes. And just a quick overview for today. Caregivers are an essential member of the patient's care team, but they're often overlooked and unsupported. Today we're going to review changes to the Centers for Medicare and Medicaid Services new physician fee schedule codes that expand and improve services for caregivers and Medicare beneficiaries. We're going to highlight a couple of cases of health systems implementing the CTS codes and the lessons learned so far. And we're also going to learn about the National Alliance for Caregiving's efforts and recommendations for integrating family caregivers into cancer care through use of these codes. We do have two additional upcoming learning communities, May 21st and June 18th. Again, thanks to those joining us, and very glad you were able to jump through the system-wide issues with Zoom to join us here today. And in just one moment, I will turn it over to Yadira. Just a reminder that we are an age-friendly health system, and this slide, of course, provides a reminder of the 4 M's. Caring for caregivers supports all of these components with a special emphasis on what matters, and that in turn affects the others and can improve the situation in all of these areas for both the caregiver and the care recipient. I'm going to place my information here. Sorry, a little bit of a delay there. And I'm going to turn it over to Yadira Montoya with the National Alliance for Caregiving for our next portion.
Thank you, Stephanie. Okay. Great. So it's a pleasure to thank you all for being here, and again for working magic so your link worked regardless of the Zoom kind of challenges and system-wide issues. So. Okay. So it's my pleasure to partner with Rush's 4C4 learning community and the Rush team to discuss the National Alliance for Caregiving, the National Alliance for Caregiving's work, as well as information about the unique challenges cancer caregivers face and what the Cancer Caregiving Collaborative is doing to address those. Before I jump into that, I want to quickly mention that NAC, or the National Alliance for Caregiving, or NAC, is a membership-based organization. We focus on transforming how the U.S. recognizes, supports, and values the 53 million family caregivers in the country who are providing complex care. And we accomplish this through caregiving research, advocacy, driving policy, systems, and culture change to elevate family caregivers as a national priority. Our organizational priorities are listed here. We're interested in championing caregiver health and wellness, promoting caregiver financial well-being, and fostering caregiving-friendly communities. And to advance our first priority, this summer we launched a big initiative, the Cancer Caregiving Collaborative, which I'll discuss in greater detail. Okay. So, as Stephanie mentioned, family caregivers are the backbone of our healthcare system. They are helping with providing complex care, including medical tasks and providing emotional support. However, their contributions are often overlooked, undervalued, and they receive inconsistent support. I wanted to share this quote with you from Abina, a family caregiver advocate, as well as a member of our executive committee of the collaborative, because it underscores this core and unfortunately common situation in cancer care, where a person can become a caregiver in an instant and thrust into a demanding role, often without little or no preparation. Now, cancer caregivers face unique challenges. They dedicate a significant amount of time caregiving, with about a third reporting that they spend over 41 hours of providing care per week. So that is, their caregiving is like an additional full-time job. Their responsibilities often include, again, complex medical decisions and medical management and medication management, excuse me. Compared to non-cancer caregivers, they also experience higher rates of emotional stress, with one in two saying that they're experiencing high emotional stress and that they feel they had no choice but to become a cancer caregiver. And apologies, the arrows in the slide are extra sensitive. So let me get back to, this is where we're supposed to be at. And cancer caregivers also express a greater need for helping manage their emotional and physical stress. Cancer caregivers also report significantly higher rates of performing complex medical and nursing tasks for their care recipients, again, often with little or inconsistent support and training. Okay, gosh. So as I mentioned, this summer, NAC launched the Cancer Caregiving Collaborative. The collaborative executive and steering committee is comprised of individuals and organizational members representing patient advocacy, industry, research, healthcare, and family caregivers. So I really encourage you to visit the collaborative's website and learn more about our partners or work, and to hear more about Abna's caregiving story, as well as other caregivers. And if you're a cancer caregiver, there's also an opportunity for you to share your story with us and help us advocate for change. The collaborative has two main priorities: championing the equitable integration of family caregivers into cancer care teams by optimizing reimbursement pathways to increase access to high-quality training, educational resources, and support services, as well as addressing the financial toxicity of cancer caregiving by advocating for smart and equitable economic policies. In alignment with these priorities, our goal for this webinar is to increase awareness about the CTS codes and their role in improving support for family caregivers and integrating them as partners and key decision makers in the care team. Our next speaker, Autumn, will discuss how the CTS codes represent a paradigm shift in supporting family caregivers through Medicare. NAC has long championed this kind of policy change, and we know that data on care coordination, activities of daily living, and high-intensity care for individuals of complex needs show that caregivers often lack support, adequate support and training. Our data, in fact, reveals that over 70% of family caregivers who are in these roles have never had a conversation with a healthcare provider about how to better provide care for their family member or their friend. At the Collaborative, we see the CTS codes as an important step in improving and equipping family caregivers with the knowledge and the skills that they need to support those they are caring for. However, to truly make caregiving sustainable, equitable, and dignified, we also must listen to family caregivers. And so when we ask them about what policies are needed to address their challenges, they overwhelmingly want financial infrastructure, policies to support their work. And so here you see in the graph the types of policies that they're interested in, like tax giver care credits, receiving direct compensation for the care. And we, as the slide says, believe that CTS is a piece of the puzzle for providing caregiver support. This quote from Pavarthi, another amazing caregiver advocate and member of the Collaborative Steering Committee, illustrates that, again, CTS codes are only part of the solution of supporting all family caregivers. The Collaborative's main goals, main strategies moving forward are peer learning and resource sharing, which is what we're doing today, policy education and advocacy, and storytelling. Specifically, this work includes advocating to improve health system and provider awareness about the CTS codes, documenting and monitoring the implementation of the CTS codes, including understanding the barriers and facilitators for code uptake. And the last thing I'll mention before turning it over to Autumn, our next speaker, is that please stay tuned. We will be releasing a brief that delves deeper into the process of CTS implementation with the focus on opportunities in a cancer setting that will highlight the two examples that you're getting, that you'll be hearing from today. So you're getting a preview, but we will be following up with a brief that includes all of this information. So before I officially turn it over to Autumn, I just want to quickly take a moment to thank all of our sponsors that are listed here. And with that, I turn it over to you, Autumn.
Great. Thank you, Yadira. Can you all hear me okay? If anyone has a verbal yes, I just want to make sure, or thumbs up.
Yes.
You're all good,
Perfect. Given the Zoom issues, I want to make sure that I have a smooth connection here. Well, thank you to Yadira and the team and the opportunity here to present to this group regarding the caregiver training services and some of the updates that were included in the calendar 2025 Medicare physician fee schedule. My name is Autumn Campbell. I am principal to West Strategies, also policy advisor to the National Alliance for Caregiving. And I do quite a bit of this work, related work, as a director of the Partnership to Align Social Care. So I've been steeped in some of this work for quite a while. As a little bit of framing, and this is really not breaking news to anyone, but the physician fee schedule is the annual rule that's published that determines how much are reimbursed for services under Medicare Part B specifically. The first physician's schedule rule was published in 1991, implemented in 1992, been published annually ever since as a guide for providing policies and reimbursement requirements for physician services. 2024 was a bit of a landmark year in the physician fee schedule because it was the first time through the PFS, the physician fee schedule, reflected a broader move towards supporting caregivers more holistically, as well as addressing what we all know of as health-related social needs, social determinants of health, etc. The calendar year 2025 physician fee schedule, which was implemented in January 1st of 2025, continues opportunities. I think it's important to recognize the environment that we are in. A lot has changed since the 2025 rule was finalized, and we'll all have to, as advocates, stay very attuned to what opportunities continue under the anticipated 2026 rulemaking. Notably, the physician fee schedule applies to Part B benefits, but also to MA and special needs plans. Ultimately, applies to all Medicare Part B providers, including federally qualified health centers and rural health centers. And it's a national policy. So it's an opportunity to make policy that is, beyond any state waiver or any localized policy initiative. Timeline is there, and as of right now, I don't think we'll be expecting any different timeline this year, but we'll keep everyone posted if things change. Again, it's important to context set here in terms of where we are at versus where we have been. Under the 2024 and 2025 physician fee schedules, they were the reflection of the then Biden administration's effort to implement a number of administration-wide initiatives, including increasing access to high-quality care and supporting caregivers, the Cancer Moonshot strategy to support family caregivers from 2022, the executive order on advancing racial equity and supporting underserved communities, and addressing determinants of health-related social needs more generally. Obviously, we know that these priorities, national priorities, have changed significantly. But I think it's important to note that regardless of that, the caregiver training services and a number of other landmark services that were included initially in the 2024 and expanded in 2025 go towards supporting a whole person health, right? And addressing what we're often referring to now as non-medical drivers of health. So outside and well beyond many of the other priorities, these services still have a really important place in the current administration's commitment to chronic disease management and, again, whole person health. So the terms may have changed, but we don't think that the overall intent and ability of these services has changed. Again, there's a lot of unknowns at this point, so we'll continue to update as necessary. That said, where we're at right now, I'm just going to skip right past that one because that slide was supposed to be a draft. It wasn't supposed to be in the slideshow. That is my bad. But this all says the same thing, just in a much more readable format. So I think it's important to understand the overview and intent of the caregiver training services under Medicare. First, they were the result of a number of years of advocacy from advocates across the community and health settings, including through the American Medical Association. They also include a broad definition of family caregiver, which is very important to advancing the broader national strategy to support family caregivers, and include pathways for caregiver training for behavior management services, assistance with activities of daily living and IADLs, as well as direct care services, the specific clinical skills that caregivers often help with. They are allowable when determined reasonable and necessary for a patient's overall treatment plan. So the caregiver training services are very much tied to what the patient needs and the services that caregiver is providing in the home. They open up opportunities early because many of the codes included in the physician fee schedule are ultimately adopted payment models for caregivers to be trained, and that training to be billed for under other types of health insurance programs, both public and private. And again, they were intended to supplement and not supplant other caregiver services. Not sure if it's cut off, but I did just note with an asterisk which of these updates were new in 2025. There were quite a bit of changes made to caregiver training services between 2024 and 2020. Some of the key details, which is actually where I want to next, is that in 2025, caregiver training services were provisionally added to the Medicare telehealth services list. If I had to look into a very foggy crystal ball, I might actually say that this might be something that is at risk in next year. So as advocates, again, it'll be really important to, to voice why that's important that these services are provided via telehealth, especially in rural areas and areas that have less access to providers. In 2025, they were also updated to ensure that verbal consent was adequate in order to move forward in caregiver training services to the caregivers. So verbal consent from the patient or representative, that was intended to eliminate a barrier that we heard in the first year of education. I think this is important as well to understand that a caregiver can be built in advance of providing CTS if that assessment is deemed necessary. The assessment is billed under a separate code. It is not required. So providers do not have to assess the caregiver's risk in order to provide CTS. And I know there's been some confusion there as well. CTS was also included in the Medicare Shared Savings Program, along with a number of other codes to address health-related social needs within the definition of primary care services. Slide I'll get into, and others will as well. There are limited practitioners who can bill, and the deductible and co-insurance applies as it would standard for Medicare Part B services. Again, I'll get into that a little bit here moving forward, but I do want to make sure that we have time for our other speakers. So the eligible providers are limited to physicians and non-physician practitioners and therapists. This is an important nuance because some of the other codes that address health-related social needs are via community health workers or other community-based providers. That is not the case for caregiving. Have to be billed in a clinical setting. This is an ongoing opportunity for advocacy, and one that NAC and others I know have weighed in on. I think some of our other speakers will get into this more, so I just want to note that that is, this is a more restrictive billing opportunity than some of the other newly added codes to address social needs or non-medical drivers of health. So there are some opportunities for advocacy here. So limited, of course, limited providers. The deductible and co-insurance, of course, still applies. And that's that 20% deductible, which would apply to the patient's deductible. However, we know that through duals populations and other supplementary insurance policies, a very limited population of Medicare beneficiaries who have that co-insurance requirement. However, it's still a barrier, and I think a number of providers have mentioned it as a barrier. And then, there's not a lot of guidance included in the fee schedule about best practices or evidence-based or evidence-informed programs for caregiver training. So there's still work to be done in helping to educate providers about some of these best practices and evidence-informed programs. Again, opportunities for advocates, talked about quite a few of them. However, I want to note that successful implementation is absolutely key here, and I'm thrilled that this webinar is focusing on implementation, and that NAC is and colleagues are pulling together a report that also focuses on implementation. That ultimately is going to be really key and critical ensuring the future of these caregiver training services. We also know payment rates, as with services, are often, if not inadequate, at least not necessarily providing a high incentive for adoption. So that is always an area for advocacy. And I'm not going to get into this at all. I just wanted to provide these slides for for context and for resource. The new caregiver training services in 2025 are included here. These include the direct care service, as well as one that I think is important to note, which I didn't, but that's the opportunity to build individual caregiver training for behavioral management services. And in 2024, those services were only available to be provided in group settings. So that was an expansion as well in 2025. Of resources here, but I will close out. I know that there are some reports that are pending. So want to make sure to highlight that and just let everyone know to look out for the implementation guide that is coming out, as well as an updated kind of policy overview of the key policy changes in the 2025 physician fee schedule related to caregiver services, caregiver training services. And with that, I will turn it over. I think I'm on time still. Turn it over to, I believe, Diane.
Thanks so much, Autumn. Appreciate great information and so thrilled to be here talking about this important topic. I am representing our Rush Caring for Caregivers program and talking about the implementation of service codes at our institution. And it's a journey, right? And it starts with a starting point and we learn as we go. And we do that by partnering with others and in keeping these open collaborative spaces to discuss and learn from each other. And it's really so important. So I won't, we've seen this slide, so I'll go ahead and pass through it. But I just wanted to kind of give the back end of what might happen even for your own health system if this isn't happening already, kind of just giving you a little bit of an insight into what happened for us here at Rush. When we're starting something new, and especially when it's around physician fee schedule codes, it starts with compliance reviewing those codes using the Medicare coverage database, and then our revenue integrity folks getting involved to then integrate those codes into our EHR for those that can be providing those services. So we have, of course, a variety of departments and staff that can do that. And then, of course, connecting that with those relative value units that are associated with each of those new codes. And then the last piece is then revenue cycle getting involved and working with our compliance department to really understand documentation requirements and, kind of doing a coding review, because that's, there's some risk there, right? There's risk to doing something new. It's not established yet. It's not clearly defined. We're not getting input on what documentation will be adequate. There's a framework there. So just a lot to kind of consider before kind of moving forward on something like this. So we initially started with using the health and behavior assessment intervention codes with our licensed clinical social workers. I am a part of our social work and community health department at Rush. So, that's kind of our thing. It's our wheelhouse. So, we are, most of us are licensed clinical social workers. And so we thought that would be a great starting point for us to really kind of work towards utilization of the new codes. And the other part of it was because the billing and coding articles were available for those codes. So, which is the official guidance on services and documentation requirements. So you're getting that kind of additional information from CMS in those articles, and the caregiver training service codes did not have that available originally. So it wasn't the first area that we decided to move forward on. So as Autumn mentioned, codes are allowing certain clinicians, and there's a few of them listed there, to bill for services that involve training a caregiver in interventions and strategies to help manage or treat the patient's condition. So I'm really going to be focusing a little bit on those caregiver behavior management training codes, because for, again, our Caring for Caregivers model here at Rush, we are utilizing licensed clinical social workers. And for our health system, we are kind of the caregiver hub, right? And for other systems where that are also utilizing our Caring for Caregivers model, it's kind of that caregiver hub for their health system as well. And so they're kind of looking to us to kind of roll these things out and kind of create the plan of rolling these out. So the codes identify the efforts of course, those providers to train caregivers regarding intervention methods that may be used to manage that disease or illness. And of course, with the licensed clinical social workers, it has to be connected to a mental health condition, which is, the caveat. We're not able to do a wider range, which again, as Autumn mentioned, certainly an area for advocacy. Autumn did list who can provide these services, but just to be clear about that again, here they are. So if you really look at this and kind of think about your own institutions and, what is the likelihood or where are those areas where these providers might actually be able to provide these kinds of services. So again, for us, with a Caring for Caregivers model at our location, it makes sense for us to use our clinical social workers and to really focus on these behavior management training codes. We also work very closely with our cancer center. We're actually embedded in that, our model's embedded in their cancer center. And within their supportive oncology area, they do have clinical psychologists as well. So we're partnering with them to really expand what services we can provide for caregivers. So just to give you an example of some of the diagnoses that, can be used or, drawn from when we're providing those caregiver behavior management trainings, these are some of the common ones that we see, for some of our older adults. And we work very closely with our movement disorders clinics and, of course, our senior care clinics. So we get a lot of our referrals from those folks. And so these are some of the diagnoses that as clinical social workers, we are then able to provide support for any of these diagnoses that, the care recipient may have and support their caregiver in training around these. So I'm not sure if it was mentioned earlier, but I think this is just that important piece to note that these codes are time-based. And so, that first code is, that initial 60 minutes. And then that second code, the 96203, is that additional 15 minutes. And you must really use up that total time and it must be documented. And if, it is subject to the CPT time rule, which is, you do the minimum of 31 minutes of time to be able to report out on those. And if you do it any less than that, it's not qualified and you can't report out on that. So for our utilization of these codes at Rush, we are planning on the following as our kind of our initial steps towards, right? So the first one would be, for caregivers that are providing care for someone with dementia. So we are an evidence-based model for dementia care for caregivers. So we have over 50% of our caregivers are caring for someone with Alzheimer's or dementia. So this is an area that we're already kind of working with caregivers on in our individual sessions and psychotherapy sessions with them. So this really gives us an opportunity to gather multiple caregivers and provide that support around behavior modification and environmental changes in the home to really support that person with dementia that may be having some behavior concerns. As well, we work very close with movement disorders, and a lot of, of course, those are connected with some dementia symptoms. And so same thing with this group, we would also be providing support and training around behavior modification and environmental changes in the home for those caregivers. And then the last one we're exploring is within our supportive oncology department in the cancer center, and that is for caregivers providing care for someone with glioblastoma. Now, that's not necessarily, that does often come with behavior concerns, but at this time, what we're going to be doing is initiating these services with our clinical psychologists within that department and just working closely with them under our Caring for Caregivers model. Oops, let me go back. So, just to kind of describe what does that look like when you're, putting this together and you're offering these services, caregivers are trained using, and this is really coming from CMS, but using verbal instruction, video, and live demonstrations, as well as feedback from the provider the provider that's providing the trainer, and the other caregivers in the group sessions. And really to, again, just address, bolster up skills and strategies to address these behaviors, whatever is impacting that patient's mental or physical health diagnosis. And then again, I mentioned earlier that, a lot of what we do currently, and this just gives us an additional area to explore, especially in a group setting with multiple caregivers, so that they can also get that peer support from each other during these sessions, is to really how to structure the environment. And, a lot of times we talk about using music and art, redirection, some of those skills that can really help monitor and manage someone with Alzheimer's or dementias, certain behaviors that come with those diseases. Oops, so sorry. So, of course, these are meant to help support compliance with the patient's treatment and clinical plan of care. So it's really important that whatever training we are providing is directly related to that care recipient, the older adults care plan, and documented accordingly. So that's really going to be that key piece, is about the documentation, which means partnership with the older adults, care team as well. So really connecting with, like I said, in our case, senior care and our movement disorders at our cancer clinic, to really talk with the providers about making sure they're very clear in their documentation that based on their patients' disease trajectory and what's going on for them, and embedding in the care plan that there's a need for the caregiver to have training in this area to support the well-being of that patient. It has to be medically necessary and with clear justifications on why we're providing those services. And of course, that has to be very documented in the medical record for each patient, the patient status, description of the caregiver status, and the services provided, and progress toward those treatment goals. So it really has to be very clearly stated what we're going to be providing and how is that going to support the care plan, and what do we expect to see happen, and document progress or confounding factors that may arise based on it, on what the treatment and support we provide. And that gives you an overview. I know we have another presenter that I want to make sure we have time to share, and then we want to open it up for questions. So I will now pass it over to Tara.
And actually, Diane, Tara is unable to join us. We've been behind the scenes back and forth trying to troubleshoot and have her log in, but unfortunately that's not the case. Tara was going to be speaking about the pilot project that she has been leading at Northwell Health. I won't dare to do justice and present her information in any way, but her pilot is on a speech pathology pilot that they did. And I want to, again, reiterate the fact that we will be, NAC is going to be, is working on a brief where we will be sharing this information that is included in this webinar, as well as highlight the information that both Diane and Tara, that Diane spoke about, and that Tara would have been speaking had she been able to join us. And so you all didn't get the preview that we wish you would have gotten. However, there is a brief, so stay tuned. And I think with that, we can turn it over to Q&A. And just really unfortunate that we weren't able to be, we can't control technology, but we move forward.
Thank you. Thank you, Dara.
Thank you all so much. I see a comment in the chat from Kate. Thank you. A question: do the caregiver codes need a physician order or other involvement, or can any of the noted eligible providers initiate and submit claims for these codes? So I'm opening that up to anyone.
I don't know, Autumn, if you wanted to take that, or if you want me to jump in.
Yeah, so the caregiver codes, would need an initiating visit, but they're not billed incident to a physician. So the other providers can bill directly for those caregiver codes. There does have to be consent documented verbally in the NAR. But in terms of the qualifying initiating visits, I'm happy to just look up real quick what that, kind of what that list looks like and put that back in the chat.
Thanks, Autumn. And I think from our understanding as well, it's really about, connecting to the care plan. So, I mean, for that, older adult recipient, that Medicare patient, it has to be very clear that there's a necessity there. And part of the care plan is, improving some part of their condition, right? So whatever aspect that is, behavior or mental health, that would be associated with, again, like what I talked about, licensed clinical social workers doing the training. And it really has to be connected and kind of recommended to a certain degree that, that training would be supporting the care plan and the benefit would be benefiting that older adult. So I think that's the key thing. And for us, we're, really wanting to make that, as smooth and clear as possible, kind of setting that framework right up front before we just kind of dive in. And so really partnering with our clinics and those providers in the clinics to really talk about what would that look like, in their notes, and how do we connect with that so that we can then provide those trainings and support that dyad.
Just as with the other, a number of other codes that address health-related social needs, it's often the evaluation and management visit that serves as that kind of initiating visit. That also is another opportunity for advocacy moving forward. Are there, whether it's a care transitions kind of assessment or another type of initiative that would be appropriate for identifying caregiver training needs. It's important to know how that's being implemented on a local level.
And Stephanie, I just wanted to point out, there's a question from Chris Herman that I think might be best fit for you, Diane, around, okay, thank you. You just changed. Has Rush found problems with conditions such as neurodegenerative disorders, which are typically diagnosed by a physician or an APP in terms of receiving reimbursement?
Well, we haven't tested those waters yet, so that we're on our pathway to do that. So that will be soon to be discovered. But we did, we communicate with CMS and we do, ask for information and we're always trying to get clarification. And we did get a response when we kind of asked about that. And we kind of got a somewhat broad response that CMS believes that individual practitioners are in the best position to determine whether particular treatments or diagnostic service are behavioral health services. So, but it's generally understood that behavioral health services would include diagnosis, evaluation, or treatment of a mental health disorder. And we were then provided with, a list of diagnosis that would be included in that. So it's part of that list that I sent you. And the reason I sent that's not all inclusive list either, it was just examples. But one of the things that, was important for me to see was that dementia was included in there as well as the neuro disorders as well. So again, that's what we're kind of hearing, but we're not sure how that's going to look like as we move forward and actually operationalize it, in all fairness. So.
I hope that answered the question, and feel free to, since we are not an enormous group here, feel free to put anything else in there. Is the list that you referenced public? Okay, good question. The list that you were discussing, Diane, whether it's available.
That's a great question, Chris, and I'm not sure if it is how public it is, or so let me look into that, and I'm happy to get back to this group on that answer. And this was kind of a direct communication that we had, so yeah, I'll have to kind of check into that. And I think, oh, I'm sorry, I'll just add, so when I say movement disorders, it's not necessarily that particular disorder, but the behavioral health that may come along with it. So, we have so many, I mean, the referrals that we get, I can speak to, our model. We get quite a few from neuro that are, that have dementia symptoms along with them. So that's kind of that focus. And then that did seem to be very clear that that was the aspect that we would be working to provide support around, not necessarily the other physical conditions that come with those movement disorders.
I'm gonna put into the chat for what this is worth. It is from 2024, and a lot of changes have occurred to the CTS codes. So, for example, they are now on the provisional telehealth service list, but there is an document that's published after the 2024 physician fee schedule regarding some commonly asked questions for the health-related social needs slate of codes, including CTS. Most of the other information to CHI and the principal and navigation codes and some of those others is less outdated than CTS, but I think this still is a helpful course in kind of walking through some of the provider questions and some of the other dynamics of CTS. So take it with a grain of salt because it is from 2024 and there have been changes in 2025. But it's at least a baseline, and we haven't seen, nor do I anticipate that we'll see anything from CMS directly regarding updated technical assistance for the CTS codes that were updated as of January 1st.
And I can take Kate's question about whether the NAC brief will focus on the codes in a medical setting, and a question around community-based providers, departments of aging, and private behavioral health practitioners. So the NAC brief will focus on medical settings, as I mentioned a little bit earlier. It will highlight the work that the amazing work that Rush is doing, as well as Northwell. And Northwell led a pilot during 2024 with speech pathologists, and so we're going to share the early implementation efforts and lessons learned, and also what's coming for this year, or what changes for 2025. And additionally, we have some recommendations, some considerations for health systems who want to implement the CTS codes. And in the list of recommendations, we include an element about an assessment for the caregiver, and include some examples for home and community-based services and assessments. And so we touch a little bit, but that's not the focus of the brief. But that's a really good question, Kate, as we think about increasing awareness and the knowledge base about these codes and how these codes are being utilized in other settings. So thank you for that question.
Other questions from the group? Feel free to put them in. We'll give a few more minutes here. Just to reiterate, if you're hearing from others, as I am, who could not get in, that the recording and slides will be sent out. So thank you all for your patience. Again, those who were able to be here. And thank you, Clara. We have a question. Hi, everyone. I'm from a program called CAP-CT. So caregivers as part of the care team. I hope I have that correct at UCSF. Thank you. And they've created billing guides that may be of interest to folks. Thank you for sharing that. Fantastic.
Yes, thank you, Clara. And part of, I know I keep mentioning this brief, but the goal is for it to be a resource, and we have included these billing guides and other information that we found that was that's out there around the CTS codes and implementation. So we will be highlighting this great resource from UCSF.
As far as Kate's question on reimbursement, I don't know that we have that data yet, but if I could be very wrong on that. So I just want to clarify, I don't know the answer to that, but somebody else might.
No, same. I mean, we don't have that information as yet, but we know there's concerns about the fact that the rates could be more robust, right? And so again, opportunity for advocacy and really ensuring that, kind of getting the word out that if we really want this to go forward and be successful, we have to have that consideration that the rates have to be they just have to be better because anything new takes a lot of, initial work and behind the scenes, and there's a lot of admin work that goes into this and clinical, it's kind of setting new workflows in place. And so, you really want to make it worthwhile, and sites might be shying away a little bit from that because of the rates. So, I mean, that's just a thought, not, I don't have any stats on that, but.
The rates and the copay have been two of the biggest barriers for implementation. And Chris, one question there, Diane, I don't know if you.
Oh, okay, let's see. If a person has early stage Alzheimer's disease, the LCSW would bill for CTS services using a diagnosis as adjustment disorder, depression, anxiety, not a dice. That's another good question, Chris. Because, I mean, certainly that could be part of it. It could be, if we assess and we diagnose with adjustment disorder. But again, this is like I'm so sorry, the diagnosis is based on the care recipient, right? That older adult. So it's really their physical or behavioral health that we're then supporting that caregiver to manage. So that's why I think that the dementia or Alzheimer's, the behavioral part of that is reasonable for us to be addressing. So that was our understanding from that communication that we had. But it could be, yes, thank you. So it could be certainly adjustment disorder for that person, if that's their diagnosis. Absolutely. We could work with that.
Just wanted to note that I think an important cohort that as implementation activities are happening, or trying to get off the ground, that when some of these specific questions or considerations come up, and it's do a lot of searching and can't necessarily find solid guidance, that it is important to share the questions that you have with the working on developing these implementation tools and resources, because without CNS doing any kind of dedicated effort on and guidance, it will be up to other organizations and advocates, and important to understand the full breadth of inquiries. If you have a question about this, chances are providers do elsewhere.
And I want to chime in really quickly to something that was part of Autumn's slides and presentation, and that is the physician fee schedule and how it gets updated every year. I know that for NAC, we do have it in our work plan to submit comments when the new changes are proposed. And not only do we submit comments on behalf of NAC, we do it for specific to cancer and our Cancer Caregiving Collaborative, and tailor the letter with a cancer focus for our Act on Race, where we talk about all family caregivers. And as part of those letters, we write out the questions, and we also request clarification on many of these items. I know that some of you on the line are also big advocates and write your own sign-on letters, but if you're looking for a template or to kind of hop on or join NAC efforts, I encourage you to sign up for a newsletter or follow up with me, send me an email so that we can alert you and let you know when those opportunities are there, so that you can add, your questions, and we can really amplify each other's kind of areas and kind of concerns and need for clarifications when we submit those letters.
Great.
I know we're at time. I appreciate all of you being here, and this will be sent out for the many, many people that couldn't join. Thank y'all so much for this great discussion and questions and presentations too.
Thank you all.
Thank you all.
Thanks, everyone.
Bye.